Welcome, everyone. This is the opportunity for our team here today to give you the updates of what we have been doing and what we are up to, and hopefully, after that we can have our other speakers we can learn from their expertise, and that's what we are here for. So I will continue on the updates that Jenna just provided, and there are going to be two different sections, I will say, the HAI section and antimicrobial resistance section in my talk, so we'll go with that. I have received Merck grant in the past, but I don't have any disclosure for today's presentation. And these are all the objectives, basically reviewing the trend of HAI in Nebraska and ARs, and what are the opportunities for us to improve on, and what are our upcoming projects, or what are we planning. So we're going to go over all of that. But first of all, want to give a shout out to all of our HAI AR team members who have put together this conference today and did a lot of good work. What I want to kind of emphasize that the team is divided into two parts here. The blue part that you are seeing are the people who, or the staff members who are credentialed at the State Health Department, and then the orange part are the ICAP and ASAP staff. But all of us are in one big team together, and this Public Health Academy partnership has allowed all the facilities here access to subject matter experts to be able to provide those feedback and assessment, and this has been great for our state, and we hopefully will be able to continue this partnership as we go along. And also want to thank you, all the HAI AR Advisory Council members, and there are, the Dr. Ranuga Vivekanand, she chairs that meeting right now. She's the current chair. They are the advisory group for us. So they provide the State Health Department advice on what we need to focus on in the HAI AR, what are the opportunities, what are the challenges, so we can guide our interventions tailored towards your need in the state. There are many different organizations that serve, or representatives of many different organizations that serves on this council. There are some openings here too, as you can see. We're kind of looking for somebody from Nebraska Medical Association. We're also looking for a dental representative, an outpatient representative, a veterinary representative on this committee. So if you are one of those and want to participate, let us know, or if you know someone, let us know. So let's now dig into the data. So CDC every year puts out an annual report for healthcare-associated infections progress in the country. And they're behind year-wise, so the most recent report they put out is the 2022 HAI report. And in 2022 HAI report, they compared, or we are able to compare ourselves from the 2021 report. And as you can see on this slide, that we have been doing good in most of our targeted healthcare-associated infections. We have a decrease in nearly all of them. On the right side here, you can see that I highlighted two areas, CAR-T and VAE, so catheter-associated tract infection and ventilator-associated event. These are the two areas where the national progress have been more than what we made in Nebraska. So we didn't reach to that same level of progress in terms of decreasing those infections as we saw at the national level. So I'm going to talk a little bit more about that, but remember that's 2022. We have 2 more years into it now. So this is another comparison, and this time the comparison for all the healthcare-associated infections from the national aspect, so where we are and where the nation is. And if you look at that, you will see that CAR-T is there still as a concern. The VAE is there still as a concern, as I was showing in the other slide. But the other area of concern has been the surgical site infection after colon procedure and surgical site infection after the hysterectomies. So that, as you can remember, probably a couple of years ago when we have been talking about it, we mentioned that Nebraska has been the worst the worst in the nation. I think we were probably #1 from the bottom. In some of these surgeries, surgical site infections, getting surgical site infections after these surgeries. So we have been focusing our efforts to kind of turn that tide. Again, we went back to the HAI-AR Advisory Council. They sanctioned for us to put together a subcommittee for focusing on the surgical site infection. So we kind of called our partners from 6 different hospitals across the state, multidisciplinary group, including physicians, surgeons, IPs, quality leaders, and they help raise awareness across the state about this. Provide some education and guide us into like what kind of resources are needed and things to that effect. They did develop a survey that was sent out to facilities across Nebraska. More than 50% of the hospital responded to the survey and provided us some information that was shared with the committee. I am not going to go into details of that survey because otherwise that will be his own talk. But I will just show different areas that were assessed on this survey. So we looked at the procedure-based questions, like, closing a colon case, what is your procedure at that? We looked at antimicrobial prophylaxis. And you can see the red areas here that are concerns because many of the facilities do not have those best practices in place at the time we were doing those surveys. The good thing about doing the survey was not only we were asking questions of what you are doing right now, but we were raising awareness of what you can actually do to help improve at the same time. And you will see this table, well, maybe here, this table that shows different group of organizations that have put down the recommendations, almost similar recommendation in certain areas that people were not following, or the organizations were not following at the time we were doing the survey. But again, we put out these education also to them along with the questions, so that it actually improve some of those practices. Again, another area we looked at is patient preparation before the surgeries, and there were some kind of gaps there too. It's the same slide, but different guidelines that are showing on the other side. So all of that happened, and after that, we started to see a decline. Now, I'm not saying that that's basically what it caused, but I think all of the effort that was raised by every team member here and the facilities themselves put a lot of effort in there. I think together with the collaboration, we are starting to see a turn in the surgical site infection data now. You have seen for years, our surgical site infections have been higher than what we should be expecting. And now in 2024, well, it's early, but in 2024, we are starting to see a significant decline in our surgical site infection. So that's a great story of the collaborative effort that we have been doing together, but mostly you guys. And then let's look at, besides surgical site infection, central line associated infection, catheter associated infection, C. difficile infection, MRSA bacteremia. We're doing better than what we are expected to do. So that's great. The CAR-T, as we were mentioning, there was a concern in 2022 that we may not be there. But as you can see, the reason we have not shifted our focus to CAR-T yet is because we are already seeing from 2022 till now, they are in a continuous decline. So we already are making some progress in catheter-associated urinary tract infection. The concern I have here, and we have to keep an eye on that, is that MRSA bacteremia, even though we are still doing pretty good, we are seeing a slow trend upwards on the MRSA bacteremia. So that's something that we want to continue to monitor as we go forward. And then the last one, the VAE that I was mentioning in 2022, that was a concern. That is still a concern, and maybe even a little more right now, because we are seeing this upward trend in the ventilator-associated, even after it has come down in the year priors. So that's something that, now the disclaimer here is that not every hospital reports the ventilator-associated events. So since we are not getting a ventilator-associated event from every place, so this may not be giving us a full picture here. But what we do know is that at least there is something here that should be dig deeper. And what we plan to do about that is to, since we're starting to see some improvement in the surgical site infection, maybe we will want to change the focus. We will bring it to the HAI-AR Advisory Council sometime within the next year, and then we will see, how they want us to proceed in this, with this infection and the interventions related to getting it down. So something to keep in mind. Okay. So that concludes the part of healthcare-associated infections, or the ones that we are monitoring. And now, kind of taking a turn towards the antimicrobial resistance or the multi-drug resistant organisms. So as you all know, in Nebraska, we have the requirement for all the labs to electronically submit all positive culture results related to Enterobacteriales, or most of the Enterobacteriales, or more common ones, along with the gram-positive organisms. So we get all that data along with this susceptibility results. So whether they are sensitive or they're resistant, we get all of that data. So over the years, you can see we get approximately 50,000 of these positive culture results for Enterobacteriales. And out of those 50,000 culture results that we are getting, we are looking into, okay, how many of them are resistant to ceftriaxone? How many of them are, or what proportion of them are resistant to carbapenem? And I think we were doing better than many of the places in the country, let's say that way. And we have been consistently around less than 5%. Now, there is data limitation here, because this is just raw data, so one patient can be mentioned here 10 times, because if they got 10 culture and they have the same organism again and again, that is over-representing this in this sample. So that limitation is there. Sometimes we also miss data of susceptibility data. So I will say like about 10% of the time we may not have results on ceftriaxone susceptibility. We're missing that for whatever reasons. But it's not more than 10%. So the 3.5%, if we even take those isolates out, might be 3.8%. So we're not that off. We are probably below 5% ceftriaxone resistance and below 1% carbapenem resistant in Enterobacteriales. Now, when you look at that statewide, you will see for ceftriaxone resistant Enterobacteriales, you will see the picture is not uniform. The picture is not uniform if you put it a rate per 100,000 population and put it into the local health department jurisdictions. You will see that there is different distinction of where you are and what rate you are going to see for ceftriaxone resistance. So we can target some efforts into the areas where we are seeing more resistance. This provides us an opportunity for prioritization. We're thinking about that. We will we'll definitely discuss more as, about this as we go forward with our planning. And on this side, you're actually seeing the rate of change between 2022 to 2023, and there are some local jurisdictions where there have been a huge increase, and then there have been some jurisdictions where we actually saw that were in blue a decrease from 2022 to 2023 in what proportion of the resistance pattern we saw. Now, the story about the differences in different parts of the state doesn't hold that much with the carbapenem-resistant Pseudomonas. So if we're looking at the carbapenem-resistant Pseudomonas aeruginosa, we're kind of seeing a uniform, mostly uniform state of resistance across the state. About 11% of all of our Pseudomonas isolates in the state are resistant to carbapenem. However, only 1% are resistant to carbapenem plus cefepime and ceftazidime. Again, I think we are doing much better than many places in the country, but we want to maintain it that way. We want to keep it that way. We want to go one step further, so say, okay, we are having those carbapenem-resistant organisms, Pseudomonas or Enterobacteriaceae, how many of those resistance is due to the production of carbapenemase enzyme? Basically, how many of them are carbapenemase producing organism, which is our higher level of concern, just because they can spread easily, and their plasmids can jump from bacteria to bacteria, can cause outbreaks. So for many different reasons, we want to kind of monitor that. And as you can see over the years, and these are different resistance mechanisms, basically genes, different resistance genes for those carbapenemase producing organisms. But the total number that we identify each year have been low. And again, we want to keep it that way. However, I can also see that every year since 2021, the numbers are more than the previous year that we are identifying. And even in 2024, we are at the pace of outpacing 2023. Now, and on this side, we also in 2023 and 2024 have seen the carbapenemase producing Pseudomonas aeruginosus. That's more recently we have started seeing, and we actually saw carbapenemase producing Acinetobacter last year. So again. These are concerned, but that may also be because we are looking hard. We don't want to miss that. We want to find them. We want to put appropriate precautions in place. Whether you are at the nursing home or whether you are at the hospital, we want you to be aware of this, and we want you to be taking precautions when you're taking care of these patients. So maybe we are looking hard, and that's why we have found some more organism, or maybe there is an actual trend. Hard to say at this point, but I'll show you the data that tells us that how hard we are looking. So if you look at the this side, what you are looking at is the NPHL, the Public Health Lab specimen submission criteria. So when they want you to test for carbapenemase enzyme, and if you don't have the capacity to do it at your place, the Public Health Lab does it for you. So they want this isolate to be transferred. And if you look at this right now, basically Enterobacteriaceae, that's the top part, and then this is the breakdown of that. We had 424 isolates that met the criteria for testing of carbapenemase enzyme. Out of the 424 isolates in the entire 2023 that met the criteria, which should have been tested for carbapenemase, we tested nearly 90%, 89% of those isolates were tested for carbapenemase. There were 10% that were discarded before we can get to that. Now, we want to even bring that number down below. This has been a huge improvement in the past. We don't have good data, but I know that number was not that high before that we were able to do those testing. So it's not that we have low number because we are not testing. If we have low numbers, even though we are doing our best to test every isolate that should have been tested. So that's good, but we want to keep it that way. So that's why CDC have this strategy of tier system, the tier 1 being the most concerning organism that we may not even have seen yet, and tier 4 is the drug-resistant organism that is endemic to our area. So we presented all this data that we just talked about to our HAI-AR Advisory Council, and then we agreed as a group together that all the carbapenemase producing organism, along with Candida auris, will fall in the tier 2 category. The ESBL organism, along with the CRPA, the carbapenem-resistant Pseudomonas or carbapenem-resistant Acinetobacter, that are not carbapenemase producing, will fall under our tier 3 strategy. So tier 2 strategy will be, you see that organism, you do the contact tracing, you do the colonization screening, you try to prevent the spread or contain the spread as much. Tier 3 strategy, we are not going to do the contact tracing, we are not going to do the colonization screening, but we are recommending that we continue our contact precautions on those patients. And if you are a nursing home, at least an enhanced barrier precaution. Enhanced barrier precaution is also recommended for the Tier 2 organisms. So Tier 2 and Tier 3, either contact precautions for the hospital or enhanced barrier precaution for the nursing home. The enhanced barrier precaution is a newer category of precautions that is specifically meant for the long-term care facilities, and it's basically target the gown and glove use, gown and glove to be used during high contact resident care activities. So dressing, bathing, changing linens, doing wound care, those type of activities. So you do the enhanced barrier precaution for that. If you kind of see the indications for which patients or which resident, nursing home residents should be on the enhanced barrier precaution, those are the ones that have wounds, regardless of whether they have MDRO or not, or if they have indwelling devices, regardless of whether they have history of MDRO or not. The idea behind is that if you have indwelling devices, if you have wound, there's a high chance, whether you know or not, that there might be a concerning MDRO there. So you just take the precaution preemptively. And then, yes, if you know about the colonization or infection, you take the precaution also. Okay, so moving on to what are we doing to kind of keep it that way, the containment, so we can keep our numbers low for a long period of time. You know, eventually everything becomes more common, but you know, for a long period of time, how can we keep it? CDC have some strategies and that they put together a guidance for public health departments that we follow. Okay, so how do they want us to do that? They want us to, step 1, determine the focus MDROs, because we have to focus. We cannot control every single thing every single day. So Tier 2 organisms is our focus. That's the carbapenemase producing organism. That's our CRS. That's our focus. The step 2, risk stratifying healthcare facilities within our jurisdiction, within our state. Which facilities are considered highly influential for MDRO spread? Highly influential is a term from the CDC plan, which means those facilities that take care of the most complex patients that have higher risk of MDROs. So our LTACs, our burn unit in acute care hospital or transplant unit in acute care hospitals or VSNF, those are our highly influential facilities. And then the next tier might be the highly connected facilities. And who are they? So the highly connected facilities are the one that frequently receive patients from these highly influential facilities. So kind of risk stratifying the facilities and then deciding in step 3 where to begin our MDRO prevention plan. So when we say where to begin, it's like which facilities we want to begin with. So I will say that, you know, when we start to kind of go in that direction, highly influential facilities will be the target to kind of start, you know, doing some strategies. And then step 4 is evaluate our clinical laboratory surveillance. And we have been doing great on that so far, as you know, all the data that we just talked about, the surveillance. So we are already doing good on that, and we are even developing more capacity at our public health lab at this point. And then, you know, finally defining a process and outcome measures. So as you saw in my presentation, there are different process measures we are monitoring already, and then, you know, definitely want to keep our resistance low for these tier 2 organisms, which will be our process measure. And then what the CDC recommends is, you know, to have those prevention strategies. Take all those steps, but what are you going to implement? There are 4 different strategies, and they want us to touch on all 4 of these strategies. So strategy 1 is conducting education. I think what we are doing today is part of that strategy already. We have also been doing monthly webinars for acute care, for long-term care, for outpatient. We have been doing social media education and targeted education for frontline workers to understand infection prevention and control. So that's another strategy we are already taking that falls in the strategy 1. In the strategy 2, the improving infection control programs, what they talk about, what they mean from that is to perform on-site infection control assessment in our highly influential, highly connected facilities. And we already do that, and we may continue to reach out to you guys if you are one of those highly influential, highly connected facilities to get just a friendly peer-to-peer feedback. Second set of eyes that comes in have nothing to do with the regulatory bodies. You guys already know that by now. So again, we may be reaching out. And then the strategy 3 is detecting the colonized individual. That means admission screening and point prevalence screening, like going in every 6 months or something to just go and do a random group of testing for tier 2 organisms in your facility if you are in, again, highly connected or highly influential facilities. That's something that we are not doing that much yet, but something to definitely consider and discuss as we go forward. We're going to be talking about more. And then facilitating communication. So that includes for all of you to communicate with each other, the nursing homes to the hospital, the hospital to hospital, nursing home to nursing home, about the transfer of these patients with known history or active infection with these tier 2, tier 3 organisms. And you guys, I think the facilities have the responsibility to transfer that information. But at the State Health Department, we take it seriously too for our tier 2 organism. And as you guys know, that we are using the Health Information Exchange for Nebraska to keep track of every single tier 2 organism and the people who are colonized with it or having infection with it. If they ever get admission into a hospital, into an ED or a nursing home, we do get alert on those people. We don't have that many in the state. I think we're monitoring less than 100 folks that have those resistant organisms. So we do get alert on that, and we usually reach out to you guys within the 24 hours to let you know, hey, check in your ER, there is a patient right now that may have a history, or that he's known to have a history of X and Y MDRO. So we are trying our best to reach out to you guys, but I think inter-facility communication is also very important in that area. So what are we planning to do in the next in next year, 2 years, or whatsoever? So those are the things that I just talked about. We will be reaching out. You can expect us to continue screening for high-risk patients. We'll think about discussing on point prevalence strategies. We will be reaching out for the on-site ICARs, and we'll continue our outreach and educational programs. And then, we are also working on putting together a whole genome sequencing program, which can help. There are papers now already showing the value of the whole genome sequencing in identifying outbreaks, in kind of focusing on which cluster to work and which cluster may not even be needing to work, because sometimes we are missing outbreaks if we are not looking, if we don't have the whole genome sequencing data, and sometimes we are over pursuing outbreaks that are probably not outbreaks. So whole genome sequencing help us get to that, and I have some examples here to show in the last year that we have used the whole genome sequencing for. So there was this cluster in Nebraska in one of the facilities where they informed us that they are seeing so many cases of Candida prophylosis coming in, and they were getting worried with having a problem with our surgeries, or is this something that is coming from the community, or what is going on that we are seeing so many Candida prophylosis cases when we usually see 2-3 a year? And we looked at that, and we did the whole genome sequencing, and it confirmed they are all related. So, when we start looking, because now we know we have to investigate that, so when we start looking, we're not finding a common source, except that all of them are being done at the lab, but there is no other thing joining those all those patients. So then we ended up doing some, or the facility itself ending up doing some cultures from their environment in the lab, and they found some Candida prophylaxis there. And then we used the whole genome sequencing to match that. And if you can see on this slide, the 0 means that the patient 2, patient 4, patient 5, patient 6, there is no difference. There is 0 difference within their SNPs in their genome. There is one patient that actually have a true infection that you can see there in patient 10, because that patient was different than the rest of the cluster. So out of all the Candida prophylaxis they saw, everything was related to the environment except one patient that actually had a true infection that was not related to that. But whole genome sequencing helped us figure that out. They took the action. And after that, since they took the action, they cleaned their lab contamination source. From there onwards, they have seen some Candida prophylaxis case as their usual baseline, which we did the whole genome sequencing and confirmed that they're not part of the ongoing cluster, but they've not seen any more environmentally sourced colonization, contamination any further. So that's the way we help them with this cluster. Another example where we were able to rule out that we don't need to do an investigation. So another facility have this, over the period of time, has seen the same organism growing from different patient cultures who were in the same units or around the same area. So there was a concern that, are we having an outbreak here? And we looked at the whole genome sequencing, and as you can see, they're much different from each other. So that basically was not a transmission event, even though it looked like a cluster. So we were able to rule out that within the last year. And then with the Candida auris, as you guys know, that we have our first transmission of Candida auris in Nebraska earlier this year, and we were able to send out the alert that we have 5 cases that we have seen in Nebraska. However, I'm glad to report that we have done a lot of contact tracing and a lot of testing, and that is not done yet. That effort is still ongoing. We're still monitoring patients and doing colonization screening to rule out that anybody exposed have actually acquired the infection. But so far, after months of effort, we have not been able to see any more Candida auris case. And the case in all the healthcare facilities that have those patients have been doing a great job in keeping it contained so far. So thank you for all your efforts in there. But this is another place where we were able to confirm using the whole genome sequencing that this transmission happened in Nebraska and how it spread. So that's last thing that I want to just mention before we close out this session. I know a couple of minutes over, but hopefully, well, let's see. Well, hopefully I have 1 minute here. So we have done over the last 1.5 years this effort to provide support to the long-term care facilities to be able to implement a fit testing program at each nursing home and assisted living facility across Nebraska, and not only having a fit testing program, but actually having someone at your facility who can continue to do annual fit testing themselves. So building the capacity within the health department and within the facility itself, and also to have them trained to get infection control training and develop infection control champion. And we were able to put financial assistance for them to be able to ask for the reimbursement for the time spent on that training or the expenses that you occurred on that training. And I'm glad to report that 183 facilities receive N95 fit testing support through this program, meaning that they train people on that. 550 staff receive fit testing and training on how to perform fit testing, and they also receive their supplies to fit test the rest of the building. 1,045 staff were actually receive fit testing or underwent fit testing by the local health department staff, and then many more probably after that by the facility staff. There were 227 facilities that received HEPA filter units, and over 1,000 HEPA filter units were distributed to long-term care facilities across Nebraska. So just wanted to let you guys know that we're doing all the best to get, not only to get these things out, which already done, but also that there is 14 days left now for you, if you participated in that, if you meet the requirement for the reimbursement, you have 14 more days to submit your invoices for reimbursement. After that, we will not be able to reimburse because we have a grant and we have to meet the deadline for the grant. So 14 more days to submit your invoices. So reach out to us if you have questions. So in summary, Nebraska hospitals are doing better in preventing most targeted healthcare-associated infections. We have low prevalence for some of the CDC-targeted MDROs, but we still need the collaboration to keep it that way as we go forward, and we look forward to that. The whole genome service that is being offered by the public health will play an important role as we go forward to assisting in identifying and limiting the MDRO transmission, and we will continue to expand our collaborations with you guys, and we'll make more progress as we go forward together. Thank you very much.